I'm Dr. Ani Danieli, and I'm a second-year fellow at Aventura Hospital in Aventura, Florida. And we're going to be going through some quality improvement projects today. Our first presenter is Dr. Kyle Schwartz.
Hi, guys. My name is Kyle Schwartz. I'm a second-year pulmonary and critical care fellow at Albert Einstein College of Medicine, Montefiore Medical Center in New York. I'm going to talk about a quality improvement study I did to reduce hyperoxia in the ICU. I'm assuming I'm just hitting the arrow over. Okay. I have nothing to disclose. So oxygen is given to many critically ill patients. We've all seen this. And, a lot of times in excess, it can have deleterious effects in the body. It's theorized free radical species, reduced coronary blood flow, increased vascular resistance, and it's a medication. It has a cost, which we all saw during the pandemic. So we did this study to reduce hyperoxia in our ICU, and we did it based on this study which showed an increased mortality on patients who were given liberal oxygen versus conservative oxygen. And they postulate their meta-analysis showed that above 94 to 96% was likely detrimental. So this is just the graph showing at the bottom here, the diamonds just showing that it was statistically significant that there was increased mortality for liberal oxygen use versus conservative oxygen use. And then our study, we used the British Thoracic Society guidelines to achieve a target saturation of 94 to 98%, unless they were hypercapnic respiratory failure, and then it was 88 to 92%. So the way we knew we had profound hyperoxia in our unit was that one of my colleagues, Dr. Agarwal, did a study in 2019, actually presented at CHEST, where she showed that patients spent a median 73% of their time above 98% satting. And then she did it by quartile. She broke it down. So the last quartile here, greater than 90%. They spent greater than 90% of their time with above 98%, and that their median FiO2 is 40%. So we weren't weaning. People are spending greater than 90% of their time above 98%. Their FiO2 is 40%. People weren't going below. So our problem is that we're not weaning below 40%. So we designed a study basically to see if we can improve this. So given that hyperoxia, it's unclear if it has a mortality benefit. It's not superior to be hyperoxic than normal oxic. And given that this prior study showed profound hyperoxia in our patients in our ICU, we designed this study in accordance with BTS guidelines to decrease the time patients spent hyperoxic. I know this is a lot on this slide, but basically we held an information session with all the respiratory therapists about lowering FiO2 and keeping patients below 98%. I collected data for 2.5 months before an intervention period, and then I did a 4-week intervention period where basically I went in 3 days a week, me and my colleague, and we had a paper, which I'll show on the next slide, describing the amount of time, the amount of time patients spent over 98%, and then their mean FiO2. So we gave them both, and patients that spent more than 50% of their time above 98%, we were like, maybe we could lower the FiO2 if it was 40%, if it was 30%. It was like, there's more room to go down. And then I gave them the articles, the BTS guidelines, and the copy of the CHOOSE study showing an increased mortality. We did a 2-week washout period, and then 2.5 months post-intervention period where I analyzed I took the data after the intervention, analyzed it. It was from one of our ICUs, and it included all patients that were mechanically ventilated for 24 hours at least, and they had to be above 18 years of age. I collected SpO2, FiO2, ICU length of stay, and mechanical ventilation duration from our EPIC charts, and I used Wilcox and Ring sum test for median values and a chi-square for categorical variables. This is just an example of the handout I had. So as you can see, MICU bed 7 and MICU bed 10, each of these patients spent more than 50% of their time above 98%, although their mean FiO2 values actually really weren't that high. But a lot of these patients would have mean FiO2 values of 40%, and they would be spending 92% of their time above 98% saturation, so we would be like, maybe that's able to wean that FiO2 down a little bit more. So results, this is from our one medical ICU, is that there were 69 patients pre and 72 patients post, similar number of SpO2 values. The median SpO2 for the pre-intervention group out of all the patients and all the values was 98. It was 95 in the post. The median FiO2 is 40% in both. And then, as you can see, the median time that these patients spent equal to or greater than 98% was 61% in the pre-intervention group, and it was only 13% in the post-intervention group. And it was statistically significant. So we were able to substantially decrease the amount of time patients spent greater than or equal to 98%. So this is a graph basically showing the number of patients and a quartile. You can ignore the numbers inside the graphs. Those are basically the median FiO2s, which I'll explain here in a second. But so basically, the blue is pre-intervention and the orange is post-intervention. The height of the graphs are the number of patients percent-wise, and then the bottom is the percent of the time they spent equal to or greater than 98%, and they're broken up by quartiles. So the first one is 0 to 25% of their time above 98%, whereas the last quartile here is 76 to 100% of their time above 98%. So as you can see, since blue is pre, almost 40% of the patients in the pre-intervention group spent 76 to 100% of their time above 98%. And then in the post-intervention group, you can see that the percent of patients in that first quartile, it was almost 70%. So almost 70% of their patients spent only 0 to 25% of their time above 98%. And only about 10% spent greater than 76 to 100% of their time above 98. So the number of patients in the first quartile group increased greatly after the intervention. So we were able to reduce the amount of time patients spent above 98%. And then you can look at the numbers inside the bars. These are the median FiO2s. So the median FiO2s are the same basically for all the quartiles except for this last quartile where they spent 76 to 100% of their time above 80%. The last quartile we were able to decrease the FiO2 from 35 to 30. So not only did we decrease the number of patients who spent their time above 98%, we also decreased their median FiO2. So I mean, in conclusion, studies are conflicted if there is an increased mortality with supertherapeutic oxygen. However, it's not superior, it seems to be, and given that it has a cost and possibly a mortality detriment, why not just avoid it? And we've demonstrated with simple education of all ICU staff, daily monitoring of SpO2 values, which we all do, we can significantly reduce supertherapeutic levels of oxygen in the ICU. And then in future direction, I mean, is the new lower limit 30? It seems like we got down to 30%. Could it be 21? I mean, also, why are these patients still intubated? That was another question we had. I mean, it could be hypercapnic respiratory failure, but there's a lot of patients. I doubt all these patients are hypercapnic respiratory failure. We didn't look at PEEP. Could PEEP wean faster also? I mean, a patient is on 30 FiO2 and a PEEP of 20 versus a PEEP of 5 is very different. And is there hyperoxia in non-vented patients? A lot of patients, it could be a bigger problem. A lot of patients we've seen in the hospital on 2 liters nasal cannula that likely don't need it. And a lot of the COVID trials are actually using oxygen-free days as an outcome. And then the study raises questions about how oxygen is weaned across different institutions. We do it differently than other institutions do it. It wasn't a standardized practice that I did to lower oxygen. I just gave them the sheet saying that this is who is hyperoxic, you lower as the protocol. So, and that was it. This is my attempt at an oxygen molecule. Yeah. Thank you. Yeah.
Our next speaker, Dr. Salim Surani.
Thank you very much. Glad to be here. First of all, I'd like to thank my students and residents who have tried to do this study. For some reason, they couldn't join because of some family emergency. So I'd like to thank all of them. I think the quality is an issue which is not a person. It has to be a team effort. And what we are trying to see more and more, that it has to be a process of continuum. We look at the organ donors, like, patient, if they're coming in, a lot of the institutions has an alert which goes on by itself. So we have an APIC system which gives the alert if your Glasgow scale is going down, or if your reflexes are going down, or if attending or neurologist has written something, and it will create an alert. And then they will try to go ahead and make a call to the life gift services. And they will try to come and initiate the process. But 169 million Americans are registered as a donor, but due to the limitation in organ donors, sometimes we can't define the timing, sometimes they're too old. Only about 3 in 1,000 people who die, their organs are somewhat useful. In the living thing, we actually are very aware that if you are going to have a stroke and you have a delay, it's causing a damage and death in the brain tissue. If you're having an MI and if you're delaying in the PTCA or the thrombolytics, you're causing death of the myocardium cells. But on the other hand, when the patient is coming in near death, I think we all may have come across when we get a transfer in our facility. Sometimes we even see the patient coming in and we say like, wow, they transferred a dead patient. They're on the ventilator, their heart is going, their blood pressure is okay, they're on little pressors, and nobody really checked it. Patient is not on paralytics, nothing, and patient has full-blown fixed pupil, their Glasgow scale is low. Then when they come in, you already lost a window because the more time it goes away, the more organ we look at it. I mean, I started doing lung transplant in 1990, and we have come a long way. And then what we are realizing that as the time goes by, the more delay we do, the more organ we are not able to harvest. So one donation can save 8 lives. You have a kidney, pancreas, liver, lung, heart, intestine. And also, if a living donor, we can still get kidney, part of lung, liver, intestine, eye, and tissue. So we hypothesize that in addition to the best practice alert on the EMR, which flags the nursing education is very important. I've seen nurses putting a Glasgow scale of 13. And if you look at the patient, they're totally obtunded and they barely have a Glasgow of 6 or 7. And question is, are we up to date with the PAR in the nursing? And especially if you look at this study most of the time, when we look at the QA process, we did it during the peak COVID time. And we had a lot of nursing turnover. And I can tell you that in our ICU, we had some pediatric nurses who were working, some of the floor or tele nurses who were working, trying to provide the best care, especially in the surge. So we look into the ICU-wide nursing education sessions, and we wanted to see that beside the best practices alert, if we can train the nurses, does it improve the outcome of our donor referral, whether we can save the tissue, we can have an increase in the referral, and how many people were actually never referred to the live gift, or how many people were delayed. So the study was done at the Houston Methodist, and we wanted to make sure, people realize the Glasgow Coma scale less than 5. We wanted to make sure that there is a loss of 1 or more brain reflexes, and the nurses can educate. So what we did with the nurses. So we started doing a session beside the computerized alert, which they get it. We had the life gift person, they come in and give a talk, and then we also train the nurses. So during the morning and evening huddle, they will start educating the nurses. We wanted to make sure that they can adequately recognize the Glasgow scale. They can pick it up. They need to know how to get the brain reflexes. They need to check the gag reflexes. We even give them the pupillometry, so make sure that they can measure the size. They need to know the ocular motion. And also we taught them about DI. I mean, sometimes if you have a brain injury and then you go into a DI, then that's another thing which you need to look into it. So when they find beside the best practices alert, if they're not flagging the alert, if the nurses are finding any of those things, then they will notify the intensivist. And if they look at it and they examine and make sure that it's in line, and then they make the live gift referral. So the data was, we compare was 6 months prior to the intervention, and then education and then intervention. We had a January 21 to June 22, 21 was the time when it was a baseline data retrospective. We looked at it. We started training them somewhere in the mid of June, and then we continued in the mid of July. And then after that, every week they were getting the huddles in the morning, and then every week they were getting enforced. The total number of timely referral in the pre and post period was 23 out of 33 and 29 out of 31. So what we realized that the computerized alerts are good, but that actually cannot always pick those things up. And also, I think this played a very important part in the COVID pandemic when we had a very high number of nursing turnover. And at the time when you're struggling with the challenge of having a rotating nurses, you're having a nurses who are sick or they wouldn't be coming, you're sometimes filling up with the tele nurses, giving them a crash program. We even have a pediatric nurses trying to work into that. We sometimes have a surgical ICU nurses coming in the medical ICU and neurosurgical ICU. So the overall timely referral of the organ transplant increased from 69.2% to 95%. Out of 4-month post-education, 2-month record, the compliance of 100%. And it was very statistically significant with a p-value of less than 0.05. So if you look into the pictorial graph, if you look at from January to June, time for the organ referral, we were running 71%. February in Houston, if you recall, I think in 2021 when we had the Delta variant, it was kind of very challenging. And then you have April 88%, then May, June, again, it dropped down because again, then we had some more surge going on at the time. We started the intervention and you start seeing the significant improvement in the trend. It was 100%, 88, 92, and 100%. And again, if you look at the tissue referral, which increased significantly. So I think, one of the key challenges that especially the QA projects are important, but when there is a time where there is you feel that either you don't have the consistent trained nurses and the trainings have been muffled, or some of the transfer of the nurses coming in, they may not be familiar with the education. There's a role for continuum of education. So you can't do it that, we have given one training in service when they are getting as a new employee, and then you feel that that's going to be adequate. Challenge, again, it's a small sample size, but again, we had a lot of nursing turnover. But despite that, if you look at what we were seeing between January and June, and then we did a 4-month follow-up, and still it's later on, it has pretty much improved significantly. So I think the main thing is overall, if just like in a living patient, we realize that if we can recognize, diagnose, and treat very timely, same is a thing applicable when you are, for some reason, you are not going to be there. The process has to be started very quickly so that you can salvage the organ. You can try to make sure that timely meetings with the patient's family has been done. And those 3-4 hours can be crucial because we know that the lung is very challenging. The first thing we lose is the lung, and then that goes the heart, and then goes the kidney and liver, and then what you're left with the tissue and the cornea. So this is very important, how we can change the number from 3 per 1,000, the donations coming out, how can we improve to 4 or 5? Because we know that significant percent of patients, they do die while waiting for the transplant. So I think obviously there is a good things to know how the different practices are. Are they just going through the standard? Is there any education which has been done to the nurses on a constant basis for their quality improvement? So I think, we have to recognize it's a teamwork, whether it's an intensivist, we need to get the nurses involved. We need to have definitely AI and the computer alerts coming in, but nothing, substitute for a good education and continuum of education. So I think, thank you very much for your time. I'll take any questions if you have, and thank you for your time. Okay, very good. If you have any questions afterward, we'll be around. Thank you.
Our next speaker is Dr. Megan Mayo.
Hi guys, my name's Megan Mayo. I'm from Florida Atlantic University. I'm currently a third-year internal medicine resident, and I am presenting a project on increasing the use of age-adjusted D-dimer, and I have nothing to disclose. Okay, so D-dimer is one of the major products released from fibrin degradation, as we all know, and its level within the blood is an effective measurement of pretest probability for venous thromboembolism. However, baseline levels tend to increase with age. Therefore, this lowers the specificity of the test by at least 10% in patients 80 years or older. Therefore, an age-adjusted D-dimer as the standard cutoff has been proposed as a mechanism to adjust for this increase of D-dimer with age. In patients older than 50, therefore, the upper limit of normal can be defined by the age times 0.1. Establishment of this age-adjusted baseline began with a bunch of multiple retrospective studies, followed by the first large meta-analysis, and that was in BMJ in 2013, showing that age-adjusted thresholds allowed for D-dimer sensitivity to remain greater than 97%. This was followed by the Adjust PE trial, which was in JAMA in 2013, and again showed that the use of age-adjusted D-dimer resulted in 500 fewer CTAs, with only 0.3% of the patients found to have an embolism at the 3-month follow-up. Finally, the real-life diagnostic outcome study, which was Relax PE, was published in Circulation in 2021, and this showed a 20% increase in negative D-dimer results using that age-adjusted threshold, with no missed venous thromboembolism identified at 3 months. So because of all this data that we have, the multiple societies have specific recommendations for the use of age-adjusted D-dimer thresholds. The European Society of Cardiology actually has a Class 1A recommendation for the use of age-adjusted D-dimer. ACP, or American College of Physicians, the 2015 Best Practice Advice, as well as the American Society of Hematology, and the American College of Emergency Physicians all recommend the use of an age-adjusted D-dimer cutoff, and this is in patients with lower intermediate risk of venous thromboembolism. So what did we do? We initially collected data within our 400-bed community hospital located in South Florida to look at the percentage of patients who were evaluated using the age-adjusted D-dimer thresholds. So at that time of the initial data collection, our EMR automatically flagged any D-dimer value greater than 0.5 as abnormal, as you can see in the demonstration here. So we looked at the span of D-dimer results over 28 months, and this was excluding all patients who tested COVID positive. Within the 28 months, we identified 3,715 D-dimer measurements, and of those, 1,054 had D-dimers that were less than the age-adjusted threshold. Of these amount, 143, or 13.6%, then went on to receive either a CT angiogram or a VQ scan, which was deemed inappropriate. So there are several harms to consider with this inappropriate imaging. Obviously, a main one is cost. And then the second one is radiation exposure. So an average CT is estimated to be approximately 5 to 10 millisieverts of radiation, and just for perspective, the average adult in the United States gets about 6.2 millisieverts per year. And then something that's often under-recognized is the discovery of incidentalomas and the stress and additional testing that this places on patients. And it's been estimated that about 45 CTs out of every 100 will find some abnormality. So in order to try to reduce the amount of unnecessary testing that went on within our hospital, we enacted an EMR messaging system that would basically remind providers to use age-adjusted thresholds. This is an example of the pop-up that providers would receive within the EMR. And from here, they would have to click one of the options to proceed to order the test or to go back and cancel the test. This alert would pop up whenever there was a D-dimer that had been ordered within the current hospital visit. So what did we find? Over the course of 6 months, we saw 1,720 D-dimer measurements, of which 371 patients had a dimer that was less than the age-adjusted threshold. And then 9.2%, or 34 patients, went on to have inappropriate imaging. And remember, this is compared to the 13.6 that had inappropriate imaging in the pre-intervention group. Therefore, we were able to reduce the number of inappropriate tests by about 4.4%. It's important to note that there were no significant age differences between the pre- and post-intervention groups. We went on to use chi-square testing for association between time, so pre- or post-intervention, and then if the test was appropriate or not. So all expected cell frequencies were greater than 5, and there was a statistically significant difference between the pre- and post-intervention testing, with a p-value of 0.21. So overall, this equates to a 6-month cost savings of about $33,000, as well as the decrease in radiation, as well as incidentaloma findings for all of these patients. Okay, so this project basically demonstrates that EMR messaging may be an effective reminder an effective tool to encourage the use of age-adjusted D-dimer thresholds prior to providers ordering further imaging. It's a simple, affordable intervention. However, there are definitely some limitations. We did have a relatively small sample size as well as a small effect size. So using the phi coefficient, the effect size was about 0.59, which was significant, but overall it was a 4.4% reduction in the amount of testing that was ordered. In addition, there's always a concern about pop-up fatigue. I'm sure all of you are familiar with the multiple pop-ups within EMR systems, and it's not uncommon for providers just to click out of the pop-up or to select an option without really fully processing what the reminder message is. In the future, we would like to create a function within the EMR that would allow for automatic integration of the age-adjusted D-dimer within the system. And then going forward, there's also some consideration about actually higher thresholds, up to 1,000 in patients with very low pretest probability. And then there's some other criteria as well that's been more explored in recent years, including the years criteria. All right. Thank you, everybody. Oh, sorry. Did you? I can stay.
Dr. Mayo, do you have any thoughts about seeing if there's any way we can improve and discourage providers from ordering D-dimers in patients who are clearly high risk?
Yeah, so that's obviously a separate issue. So if you have a high pretest probability, you should be automatically going to imaging, as you know. We didn't specifically look into that. I think, in those patients, obviously the D-dimer in theory should come back higher and then prompt them to order the imaging, but we didn't specifically look at a way to, I don't know if that would be another pop-up, but that would also be, pop-up fatigue and going on from there. I think that would be more of an educational intervention, maybe talking to the providers specifically and kind of educating on the appropriate use of D-dimer versus initial imaging. Yeah.
Were there any positive CTAs in all those patients who got inappropriate testing? And if not, that may be a way to increase your effect size by feeding back those data that said, of your excess 1,000 CTs, none of them were positive.
So we had one in the post-intervention group that had a low D-dimer, went on to get imaging, and then did show up with a subsegmental PE. But it was, one out of, however, all of those, 1 out of 34. Yeah. Anything else? All right. Thanks.
Our next speaker is Dr. Francisco Barrios.
Hello. My name is Francisco Barrios. I'm a internal medicine resident at the Dell Medical School. Our quality improvement project was called Implementing a Nurse-Driven Protocol for Supine Trials in Patients with ARDS. And I have nothing to disclose. So some background. Prone positioning has been shown to improve survival in selected patients with ARDS, as seen in the PROSEVA trial. However, during the pandemic, we saw an unprecedented amount of prone ARDS patients. And in our academic institution, we had to switch from using these beds like the rotoprone beds into actual manual flipping either to the prone position or the supine position or vice versa. And as you can see from the picture, it's a very stressful situation. There's a lot of lines, tubes, drains, and these patients were on a high amount of oxygen requirement. So initially, in the early days of the pandemic, it was our physicians that were deciding on rounds on who was safe, which of the patients that were prone, who were safe to be turned supine for things like daily skin checks or oral care. But this often happened later in the day with rounds, and there's also a lot of uneasiness with the high amount of FiO2 requirements that we saw in our patients. And this quality improvement project actually started when one of our nurses, Jessica Ibarra, asked for some structure and to help give us clarity on when we might expect to do a supine trial. So something similar to a spontaneous awakening trial or a trial of spontaneous breathing. And so our objective was to create a nurse-driven protocol by which staff could make plans for supining and reproning patients without immediate physician involvement. And so we had to first start by designing the protocol. We sent a pre-survey before rolling out the protocol. We worked with the nurses, the charge nurses, nurse educators on how to roll out the protocol and what education should come along with it. We also sent a post-survey 1 month afterwards. And so in terms of designing the protocol, the first thing that we had to do was to see, well, what resources do we have currently available? What does our staffing look like? What is our equipment? We then, based on multiple members who were interested, we created a multidisciplinary team of physicians, residents, respiratory therapists and their managers, charge nurses, and nursing education to help create a protocol and then get feedback on this protocol before we implemented the protocol, and then work with them on how to educate nurses on using them. So this is the final version of the protocol that we had distributed it to our nurses. And there's mainly 3 components here. The first part is the inclusion criteria, which of our prone intubated patients would qualify for a supine trial. Then if they met the inclusion criteria, then we would go to the decision point of actually doing the supine trial and waiting 4 hours before we determine what was the next steps based on their FiO2 requirement, whether they should stay supine or if we need to go back to the prone position. And so we did a survey before we rolled out the protocol, asking 3 different questions. The first one was, how often did you know at the beginning of your shift whether your patient would be flipped, meaning turn from the prone position to the supine position? How difficult is it to plan your daily work with a prone intubated ARDS patient? And also, how stressful is it to flip your prone intubated ARDS patient? And so the way we did this is we laminated these protocols and we put them outside the door of each of the rooms in the ICU. We worked with the charge nurses and the nurse educators to help distribute this information during huddle. And then our own medical ICU team did some daily check-in with nurses on the protocol and try to troubleshoot any concerns with the protocol. And so then we sent a survey, the same survey 1 month later, and of the 82 MICU nurses, medical ICU nurses who received the survey, 42 responded to the pre-survey, 33 responded to the post-survey. In terms of the first question of how often did you know at the beginning of your shift whether your patient would be flipped, in the pre-protocol, we had it on a Likert scale of 1 to 5, 5 being almost never. Those who rated it at a 4 out of 5, in the pre-survey was about 55% of the nurses. And then 1 month after the protocol was initiated, we saw here that the ones that rated it at a 4 out of 5 was now 18%. And with 5 being almost never that they knew at the beginning of the shift whether their patient would be flipped. In terms of how difficult it is to plan your daily work with a prone intubated ARDS patient, in the pre-protocol, 1 was least difficult, 5 was most difficult. Those who rated it a 4 out of 5 before the protocol was 52%. And then post-protocol, those who rated it a 4 out of 5 was 27%, who said that it was most difficult to plan their daily work around a prone intubated ARDS patient. And then finally, how stressful it is to flip your prone intubated ARDS patient. In the pre-protocol, those who rated it a 4 out of 5, 1 being least stressful, 5 being most stressful. The pre-survey showed 67% selected either 4 or 5. And then in the post-protocol data, those who selected either a 4 or 5 was 36%, saying it was most stressful in terms of flipping your prone intubated patients. So so the conclusions is a collaboratively developed nurse-driven protocol for supine trials in the prone intubated ARDS patient could potentially improve the clarity in the plan of care, could also facilitate the planning of the day's work and reduce stress among medical ICU nurses who manage these patients. There definitely was limitations in terms of sampling size and some bias with the way some of the questions were worded, but it was a good example of during emergent times when multiple providers and multiple healthcare members work together to create a protocol to kind of bring some clarity in an otherwise very stressful time in our ICUs. Thank you.
Did you adjust times for flipping to prone to avoid shift change or overnight and such?
Yeah, we didn't write it out, but yes, it was more, we focused more during the daytime when we had the most resources available to trial out these supine trials, but it was not specifically during the night. They could still do it, but yeah, we saw that it was more towards the morning time when there was more resources. Yeah. All right, thank you.
And our last presenter, Dr. Chong Lau.
Hello, and thank you for participating in these QI project sections. I'm John, one of the PGY3 internal medicine from Chester Medical Center. I have nothing to disclose, and my topic today is basically looking at the VT prophylaxis practice among the hospitalized patients. So the idea came when one of my patients who was admitted for COPD exacerbation complicated with bacterial pneumonia, and the first question on the second day of hospital admission, he asked me, like, why am I getting so many needle sticks? So I kind of go through, like, his length of stay was 4 days, and he was a diabetic. So the total needle stick that he received in that 4 days is about 28 needle sticks. So that is something that people who are afraid of needle stick, is a lot to them. So the current key guidelines from ACCP is that for people who have a high or moderate risk of pharmacological agents should be used for VT prophylaxis. However, those with low risk that should recommend mechanical prophylaxis, such as pneumatic compression device, which we usually commonly use in a hospital. So we try to include patients who are hospitalized on the monitor floor, and we exclude those, of course, already on anticoagulation for different reasons, and also the ICU patients and non-monitor floor. And of course, this was done during the COVID pandemic, so we exclude those patients as well. These are the risk assessment model that we use. We try to see how well physicians in hospital utilize the model to basically stratify the patients, to differentiate between high risk and low risk, and based on that, how well we actually put them on the correct prophylaxis. So we recruited about 9,000 patients. We screened through the patients. We exclude a lot of those patients, and we include 488 patients. The final numbers that we have was 469 patients, and we used that risk assessment model, and we try to look at each PADOA scoring. So those more than 4, we look at are they on DVT, the pharmacological agents, and those less than 4, are we overutilizing the chemical prophylaxis? So these are the numbers when we break down to each risk factors a lot of these patients, they have reduced mobility during the hospitalizations, and they have history of heart respiratory failure, and a lot of them are actually obese and elderly. So this put them in separate risks. So in this flow chart, we try to look at those less than 4, about 1/3 of patients who are considered low risk, but they are actually on the chemical prophylaxis on the first day on the admissions. So all these data was captured on the first day. And those more than 4, most of them, they are on the correct prophylaxis. Those without mechanical or no prophylaxis was most of them because they had bleeding risk or they have ulcers in the lower extremities. So these are the high-risk group who has more than 4 scoring, and a lot of them are actually on heparin group, heparin prophylactic, and only 1/3 of them are on Lovenox. So if we look further, all these high-risk group, most of them have a very good kidney functions. They should be on Lovenox that will reduce 2 needle sticks in a day. So in summary, Lovenox, we should consider that, especially with patients with good kidney function, and high-risk patients should always be considered to put on some kind of VT prophylaxis, either can be mechanical or pharmacological agents. Our patients did not get the prophylaxis was because of the bleeding risk and also because of the ulcerations in the lower extremities. So, for example, for the patient who has a mean stay of 4 to 6 days, we can reduce 17 needle sticks if we put them on Lovenox in the high-risk patients. For low-risk patients, we captured 180 patients. And in the low-risk group, unfortunately, most of them they are on chemical prophylactic, but instead these patients should be on mechanical. In summary, one of the points I want to make on is basically all these patients, we have to have risk assessment every day to look at whether they have more than 4. So if they are more than 4, we should put them on chemical prophylaxis. So in summary, we are very likely overutilizing VT prophylaxis in the low-risk patients, and as seen now in our patient group, 2/3 of our patients receive a chemical prophylaxis. So I think that's pretty much of my presentations. Thank you. Any questions? Yes. No. So in our patients, in all our patients, we do not have anyone got hit. One of the downside of this study was the sample size is very small.
I have a question. What does your initial order set look like when patients are in the hospital? Is like the heparin selected by default in the order set, or how does that look like?
So I understand that that's a good question. So when I did this study, we did not have Cerner or Epic. We are going to have a follow-up study. So in the beginning, our EMR, we do not have a Padua assessment tool in our EMR. So the Cerner, which is our new EMR system, we do have the Padua scoring screening tool. So they would give some kind of pre-assessment before we put the patient on the heparin or Lovenox on the admission. So hopefully we are going to do a follow-up study looking at, with the new EMR system, are we overutilizing the chemical prophylaxis in these patients? Thank you. Yeah, you have a question.
Any other questions?
All right. Thank you.
Okay, that concludes our session.